Medical students often view anatomy as an exercise in brute force memorization. You stare at a textbook and attempt to mentally index a chaotic, isolated terminology of ridges, grooves, and processes to survive your exams. The human upper limb presents a specific numerical problem, exactly 32 individual bones on each side. Memorizing each one individually guarantees complete cognitive overload. The solution is to abandon the list and map the 32 bones into 4 functional regions mapped to everyday actions. The shoulder anchors, so you shrug. The arm leverages to swing. The forearm rotates to bend. The hand manipulates to use it. These bones are active physical interfaces. Their shapes and curves exist specifically to route and protect delicate neurovascular networks. Organizing your anatomical map by these 4 regions transforms a list of 32 parts into a predictable system. When you understand the architecture, structural failure directly predicts clinical symptoms. We begin proximal to the body, at the shoulder girdle. This anchor point is built from just 2 bones. The clavicle, or collarbone, sits horizontally at the top of the chest. It is structurally vulnerable, yet it serves as the single bony bridge connecting your entire upper limb to the axial skeleton. Posterior to the clavicle sits the scapula. It utilizes several protruding landmarks to connect to surrounding structures: the acromion, the coracoid process, and the spine of the scapula. The most critical feature is the glenoid cavity, which forms the shallow receiving socket for the highly mobile shoulder joint. To remember the shoulder girdle bones, think carry some weight, C for clavicle, S for scapula. Evolution demands that a dexterous appendage prioritize mobility over stability. A lightweight, 2-bone floating anchor provides the necessary range of motion that a deeply fused, rigid joint would prevent. Moving distally, we reach the arm. In strict anatomical terms, the arm is only the region between the shoulder and the elbow. The arm contains just 1 bone, the humerus. Its head fits into the glenoid cavity. Below the head is the surgical neck, a common fracture site where the axillary nerve wraps tightly. Moving down the shaft, we find the spiral groove, which routes the radial nerve. A fracture at the midshaft damages this nerve, resulting in the immediate clinical presentation of wrist drop. At the distal end of the humerus sits the medial epicondyle. This prominence routes the ulnar nerve, creating the vulnerable mechanism commonly referred to as the funny bone. The structural rule for this region is simple: 1 arm, 1 bone, 1 humerus. The physical landscape of this single lever bone acts as a precise topographical map. The location of the fracture predicts the exact nerve palsy you will diagnose in the emergency room. The third functional region is the forearm. Here, the mechanics require a shift from a 1-bone lever to a 2-bone system, the radius and the ulna. The radius is on the thumb side, the ulna is on the little finger side. The ulna uses the olecranon to wrap around the humerus, forming the rigid elbow joint. The radius has a circular head that rotates, allowing the entire bone to pivot over the ulna. This specific rotational pivot allows you to turn your palm up and down, executing the actions of supination and pronation. While the ulna rules the elbow, the radius dominates the distal interface. It widens at the bottom to form the primary load-bearing base of the wrist joint. This wide distal base introduces a major clinical vulnerability. A fall on an outstretched hand frequently shatters the lower end of the radius, an injury known as a Colles fracture. The impact forces the wrist to bend sharply backward, producing a highly visible clinical outcome termed the dinner fork deformity. The forearm sacrifices the raw load-bearing strength of a single thick bone to provide the mechanical clearance necessary for rotational dexterity. The final region introduces immense structural density. The hand compresses 27 individual bones into a minimal surface area. At the base, 8 carpal bones form the wrist, arranged into proximal and distal rows. Moving lateral to medial, the proximal row contains the scaphoid, lunate, triquetrum, and pisiform. The distal row holds the trapezium, trapezoid, capitate, and hamate. You can lock this sequence with the sentence, "Some lovers try positions that they cannot handle." The scaphoid acts as the most frequent failure point in the wrist, often fracturing across its narrow waist. The danger lies in its retrograde blood supply. A fracture here severs that flow, cutting off blood to the proximal fragment. Without blood, the bone tissue dies. This catastrophic outcome is known as avascular necrosis. Moving to the mid-hand, 5 metacarpals form the palm. They follow a simple numbering system, counted 1 to 5 starting from the thumb side. The classic impact injury in this region occurs when punching with a closed fist, fracturing the neck of the 5th metacarpal. This is universally known as a boxer's fracture. Finally, the digits contain 14 phalanges. The math is absolute. There are 3 segments for every finger, but strictly 2 for the thumb. This dense, multi-segmented arrangement acts as the ultimate structural payoff. It converts the broad levers of the arm into high-precision manipulators. The upper limb logically divides into 32 bones, 2, 1, 2, and 27. Clinical pairs map instantly to this regional architecture. A surgical neck fracture dictates axillary nerve damage, and a midshaft fracture dictates radial damage. Distally, a radius impact predicts a Colles fracture, a scaphoid fracture threatens avascular necrosis, and a 5th metacarpal impact creates a boxer's fracture. The names on the page describe a physical landscape. The specific geometry of these bones and the routing of the nerves create a pattern of injury where structural traits help predict clinical outcomes. Utilizing a first principles framework moves you past desperate rote recall and equips you with logical deduction. Rote memorization eventually fails under pressure. Deeply understanding the architecture and its failure points allows you to trace physical symptoms back to their anatomical origin.